Hello, everybody. Welcome to the presentation today regarding pelvic pain. My name is Sue Condon, and just to remind everybody that we have all of you muted, and if you do have questions, we'll answer those at the end of the presentation in the time that we have allotted. So if you want to enter those questions into chat, Shana, my assistant, will be helping with that today. So let's get started. I can move forward. There we go. So again, my name is Sue Condon. I'm a physical therapist. I work at North Kansas City Hospital. I am the director of rehab services. I've been a physical therapist since 1990. So that if you do the math, I've been around a little while. 24 years, I've been doing pelvic floor muscle training and treatment. So it's kind of a passion of mine and something I really enjoy treating and talking about. So hopefully you'll get a little pearls of wisdom from me today with that. The first thing we need to think about when we talk about pelvic pain is where can pelvic pain be located? And that may sound obvious, but pelvic pain can actually go as high as the belly button region. So if you see on my diagram over here, and I'll kind of run my cursor, I've got arrows, yellow arrows, one at the belly button and one down at the lower vaginal region or the upper leg region. So we can think of that whole region as being pelvic pain related. Pain can be in a certain spot, but it can actually refer out. And so that's what we want to think about. The causes of pelvic pain, boy, there's a lot. It could be digestive in nature, fertility related. It could be related to the organs having growths outside of them or around them. And probably, again, my expertise comes more in that muscle because I'm a physical therapist and I understand muscles more than I understand all those other things. As far as when pelvic pain starts, there are some people that it starts in their teenage or early young adult years. Usually when there starts to be a period involved and maybe some sexual activity, that's when it's going to be discovered. Prior to that, maybe not so much. We can have pain later in life and understand sometimes that pain has a specific event related to it, such as I've seen a lot of women after they've had children say, boy, sex is painful now. It wasn't painful before the child. So we have to go explore what changed after that child. And sometimes, on a sad note, later in life, pelvic pain can be related to some sexual trauma that did occur earlier in life. And sometimes we repress some of those issues and they start coming back in our later years. And then finally, we'll think of pelvic pain as we approach menopause, are in menopause, or maybe even after menopause. And certainly we know that there's hormonal changes going, and there's really hormonal changes in all of these phases. So we can always blame hormones if we have nothing else to blame. Kind of like COVID. We just blame COVID for everything right now. So pelvic pain can come on gradually. So we talk about over time, or it can be a sudden issue. So let's talk a little bit more about characterizing pain. These are things that I want you to think about and maybe write down some thoughts before you go see your physician, because this is the kind of drill down that we really need to understand about your pain. The first one is this new pain? So we call that acute, or is this chronic? And usually the definition for acute pain is it's been going on for less than 3 months. So if this pain has been going on a year or 6 months, I would move it into the chronic phase. But if it's been 3 months or less, then it's pretty new. The next thing is it general? Does it cover a big area or a big, band, or is it localized? Could you take a finger and go, it hurts right here? And I want you to think about that too. You may have to kind of be a little more in tune with your body to say, is it more on the right side or the left side? Is it more in the front or is it more near the back? And so finding, kind of pinpointing that pain down a little further is very helpful when you're seeing a medical professional. Is the pain constant? Is it always there? No matter if you're having the best time of your life, that pain is there. Or is it come and go? Does it just come on at certain times of the day, of the week, of your month? Again, think cyclic in nature, or is it all the time? Then again, describing the pain, we'll ask, is it sharp, like a knife, like something pinching? Or is it more of a dull headache? It's just kind of always there. And some people have a little mix of both. And then what makes it worse? What makes it better? What time of day is it worse? What time of day is it better? Because there's a lot of information that will help us further discern why you're having this pain with all of those details really thought through. So those are good things for you to sit down and almost do a little diary, like it, or keep a calendar and really pinpoint this down. We really are trying to figure out when did it really start and what has made it progressively get worse. I always find if I can find the source of when it started, it helps me very much more understand kind of what's gone on over time. This is a busy slide. I'm not going to read this to you. My comment to this is, again, there's a lot of reasons for pelvic pain, and I'm going to talk more from a muscle standpoint, but I want you just to see all of these things can cause you to have some level of pelvic pain, pelvic congestion, pelvic-itis of some type. And again, it's important that we kind of drill into some of these things and rule some things out and rule some things in. So I will always say you have to start with your doctor, and it might not be your primary care doctor. No offense to any primary care doctors out there, but they have to understand so many things about the whole body that probably they're going to send you to a specialist like a gynecologist or an OBGYN physician, maybe an internal medicine physician, someone that's going to drill a little bit deeper into this area and this condition. They're going to rule out and look for signs of infection, abnormal growth. They're going to be able to run and order up all types of lab tests, all types of radiology exams, including ultrasounds, which they can do some of that in their office, but there may be more imaging tests that they want to run. They're looking for any growths or any changes. They're not going to see it on a bone x-ray. They're going to see it more where they can view the organs and the tissues and the structures. And if they're not really coming up with anything that way, then they may go surgically in and do some laparoscopic work where they can actually insert a camera and really look kind of like they're, going through the tunnels of this cave and these tubes and this cavity, so to speak, so that they can see if something's just being hidden or just not showing up. So it's very important that all of those things happen before you might get to a pelvic floor therapist. And if you aren't all through those things, we may send you back to make sure those things are ruled out. So then here comes the rehab component. So again, I've talked about this already, but we want to know when it started, how it started. We want to hear you describe it to us. We want to hear what makes it worse. I'm very focused on function. So how does it affect you? Sitting, standing, walking? How is it affecting you? Your bowel and bladder function. Does it hurt more when you have a bowel movement? Does it affect you being able to urinate and empty your bladder completely? I'm going to get kind of personal, and I'm going to get in your business a little bit. I'm going to ask you about sexual activity. I may ask you about certain positions, and is it better certain ways than other ways? Is there adequate foreplay so that those tissues are warmed up? And I will ask you about any type of sexual abuse or sexual trauma. Not that I need to know the details of that, but if there is a history of that, that's going to tell me something, and it's going to help me learn to coach you in those issues, because it's certainly going to affect future relationships. That abuser may be out of your life, but it's still going to affect you. Your pelvis And your pelvic floor has a memory, and it unfortunately can remember good things and it can remember not so good things. We're also going to look at your spine, your abdominal region, and of course your pelvis. And the reason we want to look at the spine and the abdominal region is we need to look up the chain. So the pelvis is kind of the basement. We got to go up the chain, and then we'll look even a little bit down the chain to kind of understand. Because again, we're sandwiched in between is that pelvic floor. So let's kind of get into the anatomy just a little bit. I'm not going to go into a lot of detail, but just to explain some basics. So when I'm looking at the spine, I am focused on the fact that you have these three natural curves. You have your cervical curve, your thoracic curve, and your lumbar curve. And the reason you have these curves is those are shock absorbers. If your spine can handle a lot more functional activity if it's got these three natural curves in it. If it's just straight up and down, boy, it doesn't take much to injure your spine or to have any type of pain issues. And sometimes it's pain at the base of it, which is your pelvis, and it's working up the chain or down the chain. So I want to look and see what those curves are doing. And then the base or the basement is that pelvis. That's not really a curve, so to speak. It's actually bones in there. And if you look at this picture in the middle here, I'm going to point to this triangle bone called the sacrum. Sometimes you'll hear it called your SI. And then you've got your ilions out here, and then they're connected by this little cartilage area called your pubic symphysis. So this is kind of the pelvic bowl. So let's talk about the pelvic bowl. I think that I like to describe the pelvic bowl just like that. I think of a bowl and I have some water in it. So if you look at that middle person, that's where I want your bowl to be. I want your bowl to be sitting nice and level. If it's tipped forward, okay, like the one on the left-hand side, that bowl is going to drop water out. And if I'm slouching, and that will tip my bowl backward. So these pictures, I think, do a really nice job of showing that. And I want to see how that pelvis is sitting because, again, I know you came to me for pelvic pain, but I want to understand what is happening with your back. And so your pelvis and its positioning is really important for me. This is going to put another puzzle piece into what's going on. Here's some better pictures, I think. So here's a person standing nice and tall in a neutral position over here on the top left. If she, really arches her back severely, she is going to dip that pelvis forward. And so there's a good chance that she's going to have some pain. And again, she's lost a little bit of her shock absorber because look, she's got a full U-shaped curve on this back. And we've kind of lost that thoracic curve in the middle. Likewise, this person has what we call a flat back. She's kind of, that pelvis is tipping forward, or actually it's a little more backward. Hers kind of looks like it's tipped forward. But there again, I look at her and I would say, boy, I wonder what's going on with her stomach muscles here because they just don't seem to be, kind of coming to action the way that they need to be. So I would be probably really interested with her on what's happening in that stomach. This lower picture shows that person in a sitting position, and it's important to understand because sometimes we can take some stress off if we just can't be sitting properly. And you may have a very good reason of why you're sitting really far forward because maybe you've fallen on your bottom and maybe you caused a tailbone issue. And so you had to sit forward to take some weight off of that tailbone region. And now that's causing some other issues as well. And then this is a great picture with this gentleman holding that child. What I think all of us have done that when we've had kids. And look at what that's doing to his pelvis. And we get kind of in those natural positions of holding the baby or supporting. And we're always doing it on the same side. And then all of a sudden you're coming to therapy saying, boy, I really have this pain. And I'm going to look back and see some of your habits and some of the things you're doing. So when I'm looking at this from a pelvic standpoint, I want to show you, peel away the skin and show you all these muscles that are involved. So In the lumbar region, we've got muscles that cover the spine. They're called your erectae spinae because they help to keep you erect and upright. In the front, we've got all those strong abdominal muscles. And look what happens if I were to do a C-section or something. You can just kind of imagine, and I'll show you pretty quick here how that can affect that. And then we've got these glute muscles. Those are your big butt muscles, and they're very important to that nice upright posture. But if you're having a lot of hip pain and a joint pain, your glute muscles might have shut off and aren't doing what they need to do. And then we go into these bad posture situations, and it can cause down below here some tightness in your hamstrings. We've got some core quad strength. So the biggest takeaway from this is that in order to reduce pain, we have to have balance. Kind of the secret to life is balance. If something's too tight, we need to stretch it out. If something's too loose, we need to tighten it up or strengthen it. And once we get that nice, even balance, then we usually can take care of some of that pain. And that applies no matter where you're at in the body. These are some common things you'll see near and around the pelvis. And again, I could do a whole lecture on sciatica and a whole lecture on SI joint pain. I just want to point out a couple of things here. Again, when people talk about sciatica, it's very common. We hear it a lot in our therapy world. What's happening is out from the spinal cord, you see this trail of nerves. So some people will say, oh, I don't have back pain, but I've got this pain shooting down the back of my leg. Well, it probably is coming from the back because it's probably this disc that has pushed on this nerve root that feeds down into your foot area. And guess what? That could be the real source. You may not feel the pain in the back, but the more we kind of unpeel that onion and talk about the situation that you're in, your history, how it came on, those types of things, I might conclude that I think it's coming from up here. And pretty soon we start working that direction, and all of a sudden you may say, wow, I don't have that shooting pain going down my leg anymore. So we've helped that disc move back where it needs to be. We've strengthened some muscles, and voila, you're better. SI joint pain. So the SI is your sacrum. That's that triangle bone. It connects the two iliums of your pelvis. It's a very important part of your low back patients. And again, it too has nerves that come out these little holes. And a lot of times the characteristic sign for SI joint pain that I will know right off the bat, I bet that's what it is people can take one finger, just like the picture down in the bottom right, and he'll go, it hurts right here. And I'm like, I bet it's your SI joint. And what happens is sometimes we do things like cross our legs a lot. I'm a leg crosser, and I've had SI joint pain in the past. And so we basically do some shifting of this joint and that ilium, and they're just not sitting nice and even together. I used to have two large dogs, and I hooked them together on a chain, and I held the leash with one hand, and I watched, or I should say, they watched me, at least for the first mile. And I started to find I had some SI joint pain because those dogs were pulling me forward on the right side, and my butt muscles, back to those muscles, weren't doing what they needed to do to pull it back and keep that SI joint in alignment. And so pretty soon I had that pinpoint pain, bothered me when I rolled in bed, it bothered me when I got in and out of my car. So I had to kind of go back to what are things I do a lot. I cross my legs a lot. I love to sleep on my side and have one leg hiked a little higher than the other. I bet everybody's shaking their head going, I do that. And if you've got that pinpoint pain, there could be a good chance you've got some SI joint instability. So we have to work, to get it back in alignment, help you learn to keep it in alignment, and then help you to learn to strengthen those muscles around that area. So the next thing let's go to the front of the body. So sometimes in therapy school, we didn't learn a whole lot about the front of the body because really there's some muscles there, but there's just lots of organs, and that's not in our domain. But as I became more skilled in pelvic floor, I realized that I needed to know what was going on in that quadrant region. So we divide, as a therapist, I divide it into 4 quadrants. You've got your right side, and you've got your upper and your lower, and you got your left side, upper and lower. Pretty easy. And I want you to pay attention, and I'll show you another picture, but if I'm down in this lower area, this ball here on the bottom of this picture, that's the bladder. So, and then we've got the intestines. The small intestines are here. This is the part of the large intestine. It goes up, under, and down. So anything that affects those areas is probably going to have an influence on this. Let's see it again in this view. So I'm over here on the left picture, and I'm going to just kind of get you oriented. So this is the stomach. This is the liver and diaphragm region. And here we've got this is your colon, or your large intestine. So the small intestine in this picture is cut away. There's just a little remnants, but as we digest our food from the stomach, and it gets processed through your gallbladder, and then it enters into that small intestine, kind of in a liquid form. So it's going a lot of different directions. Then it's going to come into this colon, or your large intestine, and it's going to come in right in this little area here, and then it's going to go up, across, down, and then you're going to poop it out, basically. So here, this is the uterus that's intact, and then right below there is the bladder. So if this was a male, you wouldn't have the uterus here, but you would have the bladder, and again, back behind there is the rectum. We've got all of these big arteries, your aortic valves and veins and nerves going down below. And then if I go over to this side, I've taken out the colon and I've taken out the small intestines. And wow, I've got my kidneys even deeper back there. And still look at this rich blood supply. So this is important because, again, if we've got surgeries that happen to our abdominal region, they very much can affect that pelvic floor region. So understanding kind of what's there affects the organs that's down there. It really is important. So here is the picture of scar tissue. So this diagram, so we just got through kind of showing you some anatomy. So let's say over here, this is a C-section scar. On the right hand, arm on the right hand side, this is probably a hysterectomy scar. And then this woman here probably had what's called a Whipple procedure, and maybe had some cancerous tumors removed from the pancreas or that region there. So pretty significant scars. This one doesn't look bad. But let's flip over here to this picture. If you look, this is what scar tissue would look like. This is obviously more of an illustrated picture, but I think it gives a good viewpoint of scar tissue in there. And so let's say I had a C-section scar, or I had that hysterectomy scar. That's what scar tissue is going to look like. And the other thing to know about these scars is if this person here had a C-section and she has another C-section, they're going to go on the same scar. Likewise, this person maybe had a partial hysterectomy and now they want to do a total hysterectomy. They may go through the same scar. And so they're going to make that scar become even, it's going to have to, think about a scar, cut open, it heals. Cut open again, it heals. And it just keeps building this collagen tissue around it, and pretty soon it's a pretty kind of tough tissue in there. And the reason that this is important with scar tissue and the organs is the way that our digestive system works is, think about 2 pieces of glass that have water between them, and they just kind of have a constant gliding motion. If you can see my hands, constant gliding motion. And that's what helps to move things through the digestive tract, okay? Another way to think of it is, think about a garden hose. If somebody comes up to the garden hose and kinks it, it's pretty hard to push things through that tube. And that's what will happen in these tubes of the intestinal tract, the colon, and that, is that if that scar tissue kind of adheres to that organ below it, all of a sudden, first of all, this gliding is kind of like, it doesn't want to do its job. So things aren't moving as well. And secondly, it just maybe doesn't glide as much. So it glides a little, but it stops because it hits that scar tissue. Another thing I've seen is with these, especially like this person's hysterectomy scar, that bladder, when it fills with fluid, it's like a balloon. And if there is this scar tissue up above here, it hits kind of this roof and it can't expand. And so I've seen ladies who have had this uncontrolled incontinence because they can hardly wait any time because they don't have that expansion capacity because that scar tissue blocked. And so we've got to get that scar tissue softened up and pliable so that we have that motility in the organs, like I'm talking, and we have full range of motion. Because the other thing that can happen is if you think about this person, look at that huge scar. She might become very forward, kind of slouched forward because that scar is pulling her forward. And if she's pulled forward, it's going to affect her back. She's not going to have great posture. She's not going to get that full range of motion. So boy, scarring is something we really have to pay attention to. So I look at it from a quadrant standpoint, as I was saying earlier, because I want to help that scar tissue, because I want to get back normal range of motion, normal motility, normal filling, and all of those things can help with pelvic pain. So again, I've said this before, the pelvic floor, I look at it as kind of the core or the basement of the body. Those muscles extend from the tailbone way in the back all the way up to the front here to the pubic bone and then side to side. This whole cavity is filled with pelvic floor muscles. And their function, they're kind of like a hammock. They support the organs that are above it. Again, we've got in a female, the bladder, the uterus, and the rectum. They help to close off those openings, and they have a sexual function. And if any of those muscles are disrupted for any reason, the function, which could be the closing of the opening or the ability to expand for sexual activity or even to support, is going to be impacted. How does that happen? So here's some examples of how the pelvic floor can get disrupted. And again, some of these are planned and some of these might not be planned. So if you look over here on the left-hand side, this is actually a picture of a baby being birthed through the vaginal canal. We have such a wonderful body that amazingly can adapt to let this baby come out and then it heals itself, okay? But sometimes in order to get the baby out, maybe somebody's got a pretty big head, we've got to maybe, the doctor may have to cut this area of the pelvic muscle to allow it to go a little further. Or maybe it's such a forceful push out where they have to go in with forceps to pull out, they might do some ripping of that pelvic floor muscle. And not any of us that have ever strained a muscle or torn a muscle knows that, oh boy, that takes a while to heal. And certainly these might have been a planned episiotomy, or we may have ripped a little in addition. But boy, what an impact on the pelvic floor. Thankfully, Mother Nature created it so that we heal generally pretty well, but there could be issues where we have some tightness in that. And so that's what a pelvic floor muscle therapist would focus on. Over here, I focus on this little guy that's called tailbone or your coccyx. We all have a tailbone. Very few have ever had this removed, and in fact, it's probably the last resort I'd ever go to. But think of what we've experienced this past week with the icy conditions, and if you've taken a tumble down the stairs or you've slipped and fallen on ice, wow, that little guy, for whatever reason, is so vulnerable to a fall. And so if that should happen, what I want to impress upon you here is look at all these muscles that you see on this side that come into that tailbone. And I'll show you in a minute, inside the pelvis, boy, there's tons of muscles. They attach up to that tailbone region. So it's really traumatic to that little guy if it gets a strain from a fall. And so we certainly, the other thing I will tell you is I've heard from some other peers in the field of this, that the new rage with all the Peloton bikes and that is that we're seeing some more pelvic floor pain because we're putting a lot of pressure, again, kind of on that pelvic floor muscle and that tailbone. So hopefully you're getting off that bike and doing some other activities and not just constantly sitting, because that a biker a lot of times will have some pelvic floor pain if they bike a lot. And then back to that picture of the man with the or a woman that has a child on their hip, you can kind of see how that can affect the pelvic floor muscle this way. When we are examining your pelvic floor, and this again is going to help you learn to localize where is that pain. I like to think of the pelvic floor as 3 layers deep, and I also like to use the visual of the clock, of a regular wall clock, to give you an idea. So when I look at the pelvic floor in the relation to the clock, the very front of your pelvic floor is 12 o'clock. That's your pubic bone. So if you reach down and push on something kind of hard in that pelvic floor area, that's the 12 o'clock spot. And then way in the back is the tailbone or the coccyx. So we think of that as 6 o'clock. And then your left side would be your 3 o'clock. And then your right side would be your 9 o'clock. So it's important to kind of understand those 4 quadrants of the pelvic floor, because as we examine the pelvic floor, we're going to say, is it more painful here? Is it between 12 and 3, or maybe 3 and 6? Is it between 6 and 9, or is it between 9 and 12? That's where the clock helps us, kind of like the quadrants on your stomach. And then we look at the pelvic floor in layers. This picture probably shows it a little bit better with the layers. I always like to show people my finger, and I say, just like I have labeled here, the first knuckle right at the top is kind of the beginning of the pelvic floor. So if I'm internally examining you, I'm generally going vaginally. And so if I'm over here on this pelvis, this is looking, if you were on the table, or if I was underneath you looking up. But you're usually on a table, and I can see from this angle, I've got the vaginal opening. Whoops, let me find my thing. Vaginal opening is here, and I have this rectal or anal opening here, and there's my tailbone. So my landmarks are my pubic bone is 12 o'clock, and then my tailbone is 6 o'clock. And I usually will go vaginally, and I will do layer 1 for the muscle. Then the layer 2 is a little deeper in, and then layer 3. And if you look in this viewpoint, if I was just in layer 1, I'm just right here around that opening. And then if I go a little deeper, I come over to these outer muscles. And if I go even deeper yet, I'm back at these bigger muscles, your coccygeal muscles, because back to that coccyx, there's a lot of attachments down there. And so this is a lot of times what we'll see in terms of that pelvic floor. And then again, I will have my 3 o'clock side, my 9 o'clock side. So I'm trying to pinpoint that pain as to, is it in the first layer, the second layer, or the third layer, how deep? And sometimes if someone's really painful at that first layer, we just stop there and we focus on getting that layer soft. And then we'll go a little deeper, and then we'll go a little deeper. So it isn't a force. A pelvic exam done by someone trained in pelvic floor therapy is not forceful. It should not feel traumatic. It should be very, very safe, is my comment to that. So there's so much I could tell you, but I want to just kind of talk how I would walk through this. The first thing is, like we talked earlier, is I want to localize that pain. I want to try to pinpoint it down. I don't want to be chasing it all over. I want to really try to see if we can get to truly the root of your problem. I'm going to look at the pelvis. I'm going to look at the abdominal quadrants, like I talked before. And again, I'll look at that spine region. I'm going to look for tightness and any kind of reduction in its normal mobility or normal range of motion, because usually we want that to happen first. It's just like with any other orthopedic procedure. If I don't have, like if I had a finger restriction, I need to get you full range of motion first before I can work on strengthening it. And it works that way all through the body. And that's the thing I would say, is that some people get very hooked on, well, I just need to do more Kegels. That'll help. And I get really worried about people that overdo it with Kegels, because if they've got pelvic floor pain, I will say, stop the Kegel. Stop for a little bit. And they may go, but I'm struggling. I'm having incontinence. I'm peeing my pants. And I may say, it doesn't matter how much Kegels you're doing. If you don't have that full range of motion, or if that bladder can't expand like it needs to, remember, it's like a balloon, it's not going to help your incontinence. We've got to figure out why you're having this issue. It might be that you're weak, but if you don't have, you can't strengthen a shortened muscle. Let's just put it that way. So scars are really important. And I think that, you know, I thought back when I first got into learning more about scar management and scar techniques, I thought, you know, I don't know that I was ever told as a child, or even as I grew up, like if I had a scar somewhere, that it needs to be pliable, that it needs to be soft, it should not be raised or hard or ropey like in nature. So I will, you know, the first thing I will do in an exam is I want to look at that stomach region. I'll look at the back too, but look at that stomach region and really see, do we have any scars going on? Because if there's scars in that quadrant, that's probably affecting some of the functions. So there's different approaches to softening scar tissue. There's massage techniques, there's trigger point releases, there's myofascial techniques. One of my favorite things to do is what's called visceral mobilization. And that's where we're working on those organs, that what we're focused on is the organs are not doing that glide or that motion. And so we're addressing more of that scar tissue and that restriction. And boy, what an impact when I started learning more about that technique as it made to digestion and just mobility and pain issues. So the fascinating area. And all of these are designed to restore range of motion. So for instance, if I had somebody with a C-section scar, I would work on softening that scar. I would teach the patient how to soften that scar and work that scar area. And then after working that scar area, I would have them do some, you know, range of motion and open that trunk way up, really extend and really open up, because that has been so constricted and pulled forward for so long that we've got to get you to open up and really let it have its full range of motion. And so, you know, and some of these techniques, you can come see a therapist once a week. There may be things you can't do because you can't get at the right angle. But what I would say is, okay, over the next week, this is all I want you to do. I want you to work on every hour. I want you to get that full range of motion. And amazing, people come back a week later and go, wow, that's really neat. You know, that really helped. And it does. It works really well. I've talked about this restoration of the muscles. So again, and this can apply anywhere. If you think, I want you to visualize like a bodybuilder. And bodybuilders get into this big thing where they want these big shoulders and this really poofy chest. And so they're doing all these chest presses and things like that. That's great. You've got this nice big chest, but the back is not getting equal time from that strengthening routine. And so I want that person to have as much focus on their back and those muscles between the shoulder blades as they're given the front. And if they don't, they're going to have shoulder pain. They're going to have pain in the shoulders. We call it impingement. It can cause numbness and tingling down the arms, those types of things. Not a good thing. So it's balance. It's all about balance. And the pelvis area is very important. It's that if I've got that bowl, back to that bowl, getting tipped one way or another, I want to restore some balance. And so that's another important component of pelvic floor therapy. Pelvic floor tissue. So if I'm doing an internal exam, and I have, I've just used my finger, I've got a glove on, I've got some lubricant, and I went in and I found some tightness. How do I describe that to patients? How do I describe what it feels like? I use the web space of my hand, just like this picture shows, and I say that this should be nice and pliable, really soft. That's what pelvic floor tissue should feel like. And nobody maybe has ever felt their pelvic floor tissue, and that's okay. But when you're having pain, I want you to understand what it feels like, and I hopefully want to teach you how to get into that region. So if it's really tight, I can bounce a quarter off of it, is the expression we use. And sometimes I've done this with patients, and I say, this is what I want you to go home and tell your husband. This is soft and this is tight, and I need it to be soft. And so I might teach the patient how to do some things to themselves to soften that. I might teach them how to coach their partner, how to soften that. So it's really important to understand what normal feels like and what abnormal feels like. And boy, once a patient feels that, and again, it usually takes a therapist like myself to find that and go, here's your problem. You are so tight over on this right side between 3 and 6 o'clock. I think it's about in layer 2 is about where I'm at right now. And I need you to work on getting that softer. We've got the problem. This is what we need to focus on. And so we'll teach them. There are other internal things you'll hear about biofeedback. And biofeedback is a great tool, and some therapists swear by biofeedback. They love it. It's the best thing to use. I personally am not a huge fan of biofeedback. I just find that I'm maybe more of a tactile person and I need to feel it. But therapists that are very highly skilled in biofeedback, and it might be a technique I use for people that are just really struggling to get it. It allows them to watch a computer screen and learn to relax the pelvic floor and contract the pelvic floor. And they're watching, maybe there might be a grid on the screen that they're watching. There's some animated things that they can, blow the balloon up and then let it come down. Pretty creative strategies. You've got an internal sensor or a probe that's inside the pelvic floor that's picking up on some of that. So that certainly is something that I always have in the back of my mind if I'm not getting them to learn how to relax it naturally. The problem I have with biofeedback is that you can't take it home with you. I can't send home this fancy piece of equipment. There are home, handheld biofeedback units that we can get patients, but again, if I can keep it simple without a lot of technology, that just seems to be my best approach. So back to that tight pelvic floor, I actually will teach patients, if they're comfortable, I will teach them, if they've got tightness in the pelvic floor, I will actually teach them how to go in and do an internal massage. The first thing I say is, I'm a stranger to you. I'm going to teach you how to do this. You're probably going to be much more relaxed at home doing this in the privacy of your own home. I like them to understand how that pelvic floor muscle feels. So again, I'll usually say, if it feels nice and soft, that's perfect. If it feels really tight, that's where you need to concentrate. I like to teach them to do maybe 5 minutes a day where they're just kind of going in and doing a light massage, maybe a little melting into that tissue. If I can teach them a position, they can do it with just their finger, it's the best. But they also make these tools that are pictured here called dilators. And those are used to get internal to that floor. And the way I describe it is, you can only get so far in, and you're kind of stuck by your own anatomy. So it just gives you kind of a longer finger, so to speak. And those can be great tools to use. I've also taught people how to coach their husbands or their partners on how to do some of this, because 5 minutes a day just to work that tissue is going to really make a nice impact. And that's what I want to teach them how to do. The other thing I really like to do, and this kind of goes back to range of motion, if I've got a tight pelvic floor because I had a baby and there was some ripping and there's some scarring, and now everything, everything hugs up. When a muscle is injured or cut, the natural reaction for the tissues is to come up and kind of guard or protect or get, kind of guarding. So we want to teach that muscle to be full range of motion again. So I like to teach what's called a reverse Kegel. So first we have people get very into their breathing so that they're just really shutting out the world and they're really in tune with their body. The next thing is I like them to, most people understand how to contract or pull up the pelvic floor. So I like them to do that once and then let it down to midline or the neutral position. And then I like to have them push out. And the analogies I like to use, because I'm a visual person, I like the idea of, think about a flower like a rosebud. And as it opens up in the morning and blooms nice and pretty, that's what I want your pelvic floor to do, is bloom, just open up, push out. Another great analogy is, think about what happens when you blow up a balloon. You have a natural tendency to push your pelvic floor outward. So that feeling of blowing up a balloon is another one. So people that are really tight, boy, their pelvic floor doesn't move. And so it's learning to kind of get them in touch with that pelvic floor and push it out, hold it for about 5 to 7 seconds, and then relax. And that's just so effective because, again, this pelvic floor is nice and tight. It's had some trauma, something's happened. So we got to get it to stretch out. There's some other exercises that we kind of can show them. This is my favorite one in this lower left, is the happy baby pose. So you can just visualize a baby with their legs up in the air, but this is a great one to stretch out that pelvic floor. Your downward dog movements and some of these openings. And I think this one, from a breathing standpoint, I have people put their hands on their stomach and just close their eyes and focus on that nice breathing, belly out. And as you inhale air, so it blows up. And then as you exhale, it comes in. So those are really good exercises for pelvic stretching. So the other thing to just comment on is that there's certain people that hold their stress up in their neck and their shoulders, and they just have this tension, and you walk up to them and you put your hands on them and go, relax. You're tight as a drum, and all of a sudden you start kind of massaging their neck, and all of a sudden they just kind of melt underneath you. People that have pelvic floor pain, for whatever reason, could have been a fall, could have been a trauma, could have been whatever. Sometimes that is where they hold their stress. So we call them butt grippers. So, and they never knew they were butt grippers until they started working with one of us in the pelvic floor region. And all of a sudden I say, pay attention to where your pelvic floor is. Is it up here, tight, or is it sitting on the chair, nice and relaxed? And as soon as they start to clue in to this pelvic floor and its normal range of motion and its normal mobility, it's like, wow, that's what it is. I'm a butt gripper. And so you have to teach them to just let it go. And that's where they have to focus. So one strategy I like to do is I have them put little dots in their environment, like maybe one on their bathroom mirror, one on the rear view mirror of their car, maybe one on their computer screen at work. And every time they see the red dot on their screen, I want them to stop and go, is my pelvic floor up here or is it sitting down? And amazing, as they start to really process that through, and we start to get that pelvic floor to go from this to this, it's amazing. They really have a relief cycle going on. So that is really a really important component of that. And we teach it in lots of different ways. The other area that I would talk about this is if there is a history of sexual trauma, and that's starting to come back to them later in life, as soon as, even if they're with a partner that they're very safe and they're very trustworthy of, that memory of that pelvic floor tenses up. And so by them doing some of that internal work themselves and incorporating their partner, we can get that pelvic floor not to get scared the minute something's coming at it that it thinks is that old bad memory. We just want it to be relaxed and receiving and very comfortable. So that's important with pelvic floor pain. So we've covered a lot. There's probably still questions you have. The first thing I would say is get to your doctor. If you are somebody that has pain with intercourse, pain with sitting, pain with going to the bathroom, anything like that, we've got to get to that. We've got to rule out that it's not something else going on. And if it is muscle in origin or scar tissue in origin or something of that nature, we can help you with that. And we want to help you with that. So it starts by having to unpeel those layers and get to the right doctors to do that. Pelvic floor therapy is covered by insurances. The term for pain with sex is called dyspareunia, and it is a covered benefit. I've not had an experience yet where I've had any difficulty seeing a patient with that as the diagnosis, because it's a function of what the pelvic floor does. So it's a covered service, and we want to help you. And again, we want you to get that control back and not let that pain control you. So I will open it up for questions.
All right, if you have any questions, please go ahead and put them in the Q&A. Sue, you did such a good job on that. I'm not sure that we're going to have a ton of questions. So let's see. I think the questions that I had as we went, you truly did answer all of them.
Okay, good.
So we're just going to give it a couple of more seconds, but also if we do end and anybody comes up with a question, please feel free to reach out to Dottie or Community Health and Wellness, and we can see if we can't get answers to it. All right, Sue, it looks like we are good.
All right.
Oh, wait,